to start.
Let's go ahead and get started then. So I'll be presenting Journal Club today. I'm going to talk about two different articles dealing with living donor transplantation for patients with hepatocellular carcinoma. So just a little bit of background. As many of us know, HCC, no pun intended, is a growing problem with an incidence of 30,000 new cases a year. Unfortunately, only about 25% of patients are receiving a transplant. Of approximately 6,000 transplants per year, an even smaller number, only 1,300 of those patients are eventually being transplanted for HCC, with 15% of patients with a liver cancer dying on the transplant list. Again, as we know, patients who have these very advanced tumors have limited options because they're outside of Milan criteria, so transplant off the bat is not an option. Oftentimes these tumors can be very aggressive, and this may be an even bigger area of concern given the impending changes that are going to happen with the tumor points disappearing come December. So patients who are downstage are going to have an even longer time period to wait before they're able to receive a transplant. Because of this, living donor transplantation has been proposed as a solution for patients who have very advanced liver cancers. So there's been some ongoing controversy about the use of living donor transplant for patients with HCC. Based on some small retrospective data, there's a study coming out of the A2L Living Donor Consortium from several years ago showing a higher recurrence rate in those who underwent living donor, with about 30% recurrence as opposed to no recurrence in the deceased donor cohort. Certainly the study had some flaws. It was critiqued as there was a very short follow-up period. Again, it was retrospective. And then it's an older study, so about over half of the patients who were included were pre-MELD error and pre-Milan error. So it's sort of unclear if the different groups were adequately matched between the living donor and the deceased donor cohorts. Another big concern is that with living donor transplant, you're eliminating the ability to observe the biology of the tumor, meaning that if you have somebody who's put on the deceased donor transplant list, you have time while they're waiting to get the organ to see if it's a very aggressive tumor that's going to sort of, spread outside of Milan, sort of regardless of what you do. With living donor transplant, obviously you're scheduling the surgery, so there's a much shorter wait time. So you don't get to see how aggressive the tumor is sometimes. So that was one of the major critiques. The other one was that despite being a higher recurrence in the living donor cohort, there was actually, interestingly, no difference in mortality between the two different arms. And mortality was even lower, actually, in the living donor group.
So they were like just small recurrences that were treated and had no impact otherwise?
Yeah, so the patients actually had confined survival, so it wasn't really significant clinically. I mean, it was significant, but maybe not as much as what it originally seemed to be. On the flip side, there have been some more recent data that have shown that there are actually a similar recurrence in patients who are undergoing living donor versus deceased donor transplant, with survival rates between 60 to 70% in the two different groups. And one of the theories over why the survival may be better with living donor is that the graft may actually be a better graft because these are coming from young, healthy patients who are in their 30s and really have 0 to very minor medical comorbidities. Also, they noted that when they were adjusting for differences between the MELD score and tumor characteristics, some of the issues with recurrence sort of fell away between the living donor and the deceased donor groups. Many of the other critiques that were brought up in terms of the studies that originally showed higher recurrence in the living group was there's differences in waiting time, which we mentioned previously with not being able to observe tumor biology. Number two, the living donor group often had more advanced tumors because these are patients who by default aren't able to be put on the deceased donor list in a lot of cases because they're outside of Milan criteria. And then finally, for whatever reason, these patients are receiving less liver-directed therapy. And I couldn't figure out why this was. I don't know if this was under the correct or incorrect assumption that maybe these patients were going to receive a liver imminently, that they didn't want to proceed with liver-directed therapy because they thought they could potentially cure the cancer very quickly. But it wasn't really readily apparent to me. So there's still this controversy that exists to some extent over living donor transplant for HCC, but what I'm going to talk about today in this particular article looks at using small for size grafts in patients who have a history of HCC with living donor transplant.
Danielle, in any of those, was there discussion about like the active regeneration happening in I mean, it's so different. Like with a living related, I mean, there's so much regeneration happening. Blood flow to the liver is going to be very, very different compared to deceased, which you're just on block putting in the full organ with limited regeneration.
Yeah, so they actually talk a little bit about that in one of the papers I'm going to present today. They don't go into a ton of depth, but they do talk a little bit more about potentially increased VEGF and sort of the potential that has to maybe increase the risk of recurrence because it's making a really good milieu, so to speak, for tumor cells to regenerate. So that was one of the sort of hypotheses, but there's no hard data to say that from the two studies I'm going to present today. So the specific aim of this study was to look at the effect of small for size grafts on HCC recurrence, specifically in a living donor transplant population. And the authors of this study postulated that this would not lead to increased HCC recurrence. The main outcomes, again, were HCC recurrence, overall survival, and HCC-free survival. And they defined small for size grafts as a graft to recipient weight ratio of less than 0.8. So this was a retrospective review using a prospectively collected database between January of 2005 to December of 2015, using 400 consecutive patients that were propensity score matched. There were a larger number of patients certainly in the graft to recipient weight ratio group of adequate via our terms of greater than 0.8, about 250, versus 82 patients in the small for size group. This was a study that was done in Korea at a large academic medical center, and patients were included so long as they were over the age of 18 and had a living donor transplant for an indication of HCC. Any patient who had a mixed tumor was excluded from the study. So the right lobe was used for all of the patients in this particular study. All of the biliary anastomoses were duct to duct. Their immunosuppression regimen is as follows above. A little bit different because they're using basiliximab after transplant, whereas we don't routinely do that here. And they also, interestingly, are not routinely giving CMV prophylaxis after transplant, but very closely following patients. In terms of follow-up, patients were coming back frequently. They were having weekly to monthly follow-up with AFP, LFTs, and then liver imaging was done with a triple-phase liver protocol CT, as well as a chest CT every 3 to 6 months. If there was any concern over recurrence, the patients ended up getting an MRI of the abdomen and a PET CT. So they randomly matched patients using propensity score matching for the variables that are listed above. Notably, most of the components of the child and the MELD score, ischemia time, blood loss in the OR, and certainly presence of microvascular invasion, and then tumor size and number. And then they looked at both HCC recurrence and patient survival in relation to graft recipient weight ratio using Kaplan-Meier curves, and then further broke down a sub-analysis looking at Milan criteria and the effect of size on patients who are inside versus outside of Milan criteria. So this is the first half of their table one. This is rather small here. So on average, the recipients were in the mid-50s, donors were in the range of 33 years old. One significant difference from their study as opposed to a study we would do at our center is the majority of patients have hepatitis B, about 90% of them. Overall, these were patients that were relatively healthy. On the next slide, you can see most of them were Child's Q A on average and had a MELD score of 11, which is sort of what's typical for studies of patients who are done with HCC because their biologic MELD doesn't really fit their recurrence risk. And then the percentages of microvascular invasion are listed here below. So there's a significant number of patients who did have pretty extended criteria. So this is looking at their first outcome, which was tumor-free survival. And this graph shows recurrence-free survival here over time. And we're looking at the effect of the size of the graft. They really found no significant difference in tumor recurrence over time via graft size. This graph here just shows, again, by size for small graft patients. The 5-year survival was 72% as opposed to 78%. These are pretty good figures. And then looking at mortality, again, no real difference in mortality over time for a low graft weight patient. And then in a 30-day mortality period, really just one patient, passed away in each group. Again, overall survival at 5 years, 79% in the smaller graft size group versus 84% in the normal graft size group. Then the authors went on to further risk stratify the patients, looking at the effect of the Milan criteria on outcomes based on graft size. This is looking only at patients who are within Milan criteria. criteria. And what they found is, again, there was no difference in either recurrence or survival for patients who were inside Milan criteria, whether they had a small graft or a normal size graft. On the other hand, there was a pretty significant difference in looking at patients who were outside Milan or had extended criteria. And for patients who had a small graft, their overall survival is depicted by the dashed line here was significantly less compared to those who had a normal size graft, and so was their recurrence in terms of HCC. That being said, it's pretty close to the significant ratio, which I think is interesting to note here. The other thing that's interesting is even with a small for size graft, the 5-year numbers are certainly significantly lower than the normal size graft, but this is pretty close to the 5-year within Milan reported variable of 70%. From what I was able to look up.
Help me understand why would they choose this? Why would they choose routinely do small for size graft? Is it just intentional, accidental? Was it for the study?
Yeah, it seems like it was intentional because they stratified the groups out. And here we wouldn't really use small for size grafts because of the risk of small for size syndrome. And so I'm not sure exactly why. I mean, it was done in Korea. I don't know because they have they don't have a big deceased donor population to choose from. I don't know if maybe they don't have other options, if they're sort of forced to use some grafts that are less than optimal. I mean, here, I think we would not do that. But
yeah, I mean, that's the thing. You're going to compare to, forget about HCC for a second, and you just look at outcomes just based on the small for size. I don't know what the 5-year survival is, just forget about HCC for a second.
With the small, I don't know.
Because it could have nothing to do with it.
But that is for the recurrence-free survival for those who have been within Milan criteria doesn't seem to be different.
For the ones who are within Milan, which is the prior, it's really no different. But once they're outside of Milan, having a smaller graft means that you're at a higher risk of having recurrence.
Yeah, sorry, for the people who were small, did they say what was the lowest? What was the median, graft recipient ratio?
It's pretty close to the 0. It's not that far off of what it's not like some crazy low number. I can't remember the exact percentage, but I think it was 0.7 to 0.8 in that range, pretty close. Nobody's getting a super small graft.
Probably figure it's close enough.
Yeah, I don't see the magic between less and more than 0.8. I'm not sure why they even look into this, because if it's a living related transplant, they're all going to regenerate. So I'm not sure what that magic is between less than 0.8 versus 1. I'm not sure why they expect to see that.
In terms of the HCC recurrence, you mean? Yeah, I think that I'll talk about this again, but their whole thinking is just that with a smaller graft that you have more VEGF that occurs and more shear stress, which increases the VEGF, and that may be an environment where you get increased tumor cell proliferation, I guess.
Well, it's not just VEGF, it would be hepatocyte growth factor, EGF, a lot of nitrogen.
But they're not getting small for size syndrome. These people are still doing
No, it sounds like these patients are doing pretty well overall.
They actually report that the number of patients that develop small size.
They do not. But the overall survival rates are pretty good, but they don't report how many are getting small.
Yeah, but if you look at the overall survival, the extending, not in Milan. Here, most of the deaths happen within the first year.
Yeah. So maybe a lot of them are small for size, I don't know. Yeah. They don't really get into that level of fine detail about what the cause of death is in the patients.
They're recurring early too. So that's recurrence-free survival.
This is recurrence free, so a lot of them are recurring, and then this is just overall survival.
It's not just liver failure.
Yeah, there's a significant portion of recurrence.
Did they mention about the recurrence rate?
Yeah, so the, sorry, I didn't have room to put on the slide here, but I can email you the numbers, but the recurrence rate is significantly higher only for the patients who have a small for size graft. Otherwise, it's equal for those who are within Milan.
And I guess are they still matched even if they are beyond Milan? Are they sort of comfortable?
So they did a propensity score match. I think they tried to match people as best as they could, but it's not a fully randomized.
Because I can imagine them taking smaller grafts for people with advanced HCC just because they don't have time.
Yeah. And this is essentially the same graphic, just comparing directly inside Milan patients versus outside by graft wave side, and just sort of a significant difference in both recurrence-free survival and overall survival with the number of patients at risk.
Could you go back?
Sure. This one?
It's strange to me that the p-value is exactly the same. On the next one.
So these are the same graphs. They're just superimposed with the other graphs. Is that what you?
Yeah, but it's 0.047, 0.049.
Oh yeah, that they're so similar.
Strange. The other thing that was a little weird is that the donor age was exactly 33.4.
In both groups.
All three groups.
Oh. It's like a pickup.
I don't know. I ain't saying it was
That looks like they did like a autocorrect.
I'm sorry. I didn't-
No?
Maybe it's like a
Propensity match. I mean, I can't imagine anybody dying that early from the curve.
propensity match.
Yeah. You would expect it to be a little bit further.
I would expect, I mean, even if we had recurrence after transplant, I mean, most people do live a year or 2 or 3. So everybody's dying within a year. So that's. I don't know whether this is a true reflection of HCC versus graft function.
I don't know. I mean, I think there are a lot of things that unfortunately we don't know. Like they're also, I mean, this probably isn't a big portion for why people would die, but they're not prophylactic for CMV. There's also a much higher rate of HPV in this cohort. It's like 90% HPV patients. I don't know if that plays in part if they're not well controlled into recurrence or, we don't know what their viremic level was. Presumably it was negative, but we don't really have any of that data.
What is the largest tumor in transplant? Just go back to your matching.
The largest what? I'm sorry.
The size of the tumor, like when they're matching it.
Yeah, sure. So
After 3.5.
that's what it looks like. So this is the median. So 3.5 and 3.5. Yeah, everything's exactly the same. Interesting.
So 10% have major vessel.
Yeah. I don't know, these are like pretty.
That's why I do journal club.
I guess it's implied that those who have major tumor, major vessel invasion are likely the ones who recur within a year. I hope so.
Yeah.
They don't say.
We don't say. I'm not sure.
In the small graph.
All grafts, they definitely
Yeah.
have worse tumors.
Yeah.
They definitely have worse tumors.
So basically, their conclusions were that the graft side essentially doesn't reflect either recurrence or overall survival in patients who are within Milan, but certainly you have to be a little bit more careful when you have these big extended criteria donors with using a smaller size graft. And then some of I think one of the good things I think they did do with the cellular, certainly there are a lot of flaws, is they used a population that was all just living donor patients instead of comparing living donor to deceased donor to sort of avoid a lot of the confounding factors that we talked about previously in terms of differences in ischemic time and differences in wait less time. So I think that was one thing they did a good job of. Certainly, there's a lack of survival difference for the patients in the Milan group. Suggests that they thought that this may suggest that the prior studies had some differences that were just due to the matching and how those studies were done previously. Was one of the critiques that came out of this paper. And then this is what we have already kind of talked about in terms of increased shear stress and the small grafts and the increased turnover and regeneration that's happening more quickly leads to increased potential for tumor proliferation.
Would have been a lot more interesting if they actually measured it.
Yeah, it would have been nice if they would have actually. Yeah. It was just kind of a theory. So again, clinical implications, avoiding maybe low graft sizes and extended donor recipients. I think just ethically, is it something that we should be doing to do a living donor transplant for patients who are beyond Milan, especially if the outcomes are potentially worse. And the study, I think, certainly leaves a lot lacking that we don't know. I don't know if there's enough data to really say that. And for these patients, certainly they don't have other options, so this is sort of their last chance. But there's a big risk to the donor, so it's just something to keep in mind. Who's otherwise a normal, healthy person. And then the last thing is if this VEGF is really, at the heart of this, is there a role for some sort of antagonist to try to help slow this down? And I don't know the answer to that.
At the risk of your liver regenerating.
The answer is no. Because this was tried, so there was a VEGF receptor antagonist that's still in use for other cancers called Sutent that was tried in liver cancer, and there were a handful of deaths because presumably you so completely blocked regeneration. They died from liver failure. They didn't die from cancer.
And those were right after transplant, or was that some time out from transplant?
It wasn't transplant, it was resection.
It was resection.
Or it was either resection or just primary therapy, rescue, the second line therapy after survival. I don't remember.
Interesting. Okay. Not an option.
I guess they didn't do the multivariate analysis to find which is independent factor or something. So I guess if they put everything together, maybe the week factor for survival.
Yeah, and they're not very detailed about how small the grafts were that were small for size. I mean, they say that it was pretty close to the 0.8 cutoff. They don't mention why patients died after transplant and the sort of exact numbers of that.
Yeah, but and also just the macrovascular invasion. I mean, if that was the predictor of poor outcomes and invasion, and it has nothing to do with the right.
Yeah.
Because Kaplan-Meier can also be held. So even though there's difference in Kaplan-Meier,
what journal was it?
This actually came out of liver transplantation. I think we've already talked about that. Any other questions on that?
I think Damon's point is really good. We don't know whether it's a graft size.
Yeah. So the second article I'm going to talk about today is basically a pilot study that was done by Joseph's group looking at living donor liver transplant for patients with HCC who are beyond Milan criteria. And these in particular, their Barcelona clinic extended criteria, which I'll define as we go through the presentation. So as we all know, survival rates post-transplant for HCC are lower than other indications. The one-year actuarial survival previously has been reported between 82 to 90%, with a 10-year survival of only 45%. So the aims of this study was to assess outcomes for extended criteria recipients after receiving a living donor transplant. Their hypothesis is that you could achieve favorable recurrence and survival rates in carefully selected patients. And they looked at outcomes of recurrence, overall survival, and then complication rates to ensure that this is something that's safe and ethical to be doing for living donors, or donors rather. So this is what they use as their BCLC extended criteria. So there's both a size and a number of criteria here. You could have one tumor that was up to 7 centimeters, multinodular tumor burden with 3 tumors less than 5, or 5 nodules less than 3. And then they also included patients who were downstage to Milan criteria. So before they proceeded with the main study, they did a feasibility study just to ensure they could, collect enough patients and that the study made sense. They looked at a large number of patients, 381. And then from that 381 patients, they only had 34 patients that were eligible for living donor liver transplant. And then after weeding out patients who either didn't have a donor or couldn't get a living donor match because of ABO incompatibility, medical comorbidities, etc., they ended up having a total of 9 patients that were left out of this sample of 381. And they calculated that they would need roughly 20 patients to be able to do the study. Ultimately, they ended up with a sample of 22 patients, so just over, and this was collected over a period of 14 years. So this is their study design. They included patients who had HCC per AASLD criteria, anybody who was in the ages of 18 to 70 using this BCLC extended criteria. If patients had an AFP that was very high, over 1,000, they had a laparoscopic ultrasound to better clarify this. And if there was any doubt about whether or not they had tumor thrombus or bland thrombus, they received a biopsy. They had to have good performance status and then child A or B cirrhosis. Patients who were excluded were those who had a tumor greater than 7, so outside of BCLC criteria, or vascular invasion, extrahepatic disease, or poor underlying liver function, child's QC. So looking at the 22 candidates that they ultimately selected, 5 of them underwent downstaging and 17 had extended donor criteria. All 5 of the downstage patients received TACE and ended up being within Milan. Of the patients who went for extended criteria, 7 of them received treatment and 5 of them were within Milan at the time of the study, 12 of them were still outside of Milan criteria. So basically the median time between evaluation and living donor transplant was 4.5 months. They used the right lobe of the liver in all of the patients. Immunosuppression regimen listed below. They had very stringent follow-up, seen monthly for the first year, or first month and a half, and then every other month for the first year. And then they had labs and scans for every visit for the first 2 years. This is their table 1 of the different patient characteristics. Again, here recipient age in the mid-50s, more similar to our sample, but not exactly the same. They had a higher number of HCV patients, 63%. In terms of the specific criteria for expanded criteria, the majority of patients were either downstaged or had multinodular tumor, with a small number having one very large tumor. And then in terms of other factors like AFP, the majority had low to normal AFP, and all patients were child A or B. They also broke down the histology of the patients that they included. Some of these patients actually had very advanced tumors. On average, the size of the largest tumor was 3.2 centimeters. A number of tumors had microvascular invasion, about 50%, or 40% who had satellite nodules. And then there were a number who were beyond Milan, the majority of the sample, 81%, 72%. So those patients had very extensive tumor burden. So looking at one of their primary outcomes, survival, overall in the entire cohort, they followed the patients for on average 81 months and found that 8 patients overall in the sample died out of 22, and 4 of those related to HCC in particular. This graph down here shows all extended criteria patients in survival at 1 through 10 years, with a 10-year survival of 69%, which is acceptable. And this is comparison to prior studies, just kind of pulled from my literature review of patients who are within Milan. And as you can see, the rates are actually similar, if not better, although there may be some confounding because of time and us getting better with liver-directed therapy over the years as well.
And the non-HCC related or still liver related?
The non-HCC related, I have a table actually on the next slide. Thank you for that segue. So complications of Hep C cirrhosis and then hepatitis, so all liver related at the end of the day. And then one of the other things I thought was interesting to note, I think this goes back to what Dr. Grewal was saying earlier, is that only one of the patients recurred very early from HCC at 17 months, whereas the other recurrences are pretty far out. Some of them a little even further out than I think we would expect, which I'll talk a little bit more about later. So this here looks at HCC recurrence in the extended criteria patients. Again, they had 5 and 10-year recurrence rates of 23 to 44%. A total of 7 patients out of 22 had recurrence, 2 in the liver only, 5 with recurrence outside of the liver. And I think one of the things that was interesting to note was that out of all the patients who recurred, they had recurrent Hep C, and they also had cirrhosis on biopsy in 5 out of the 7 patients. And then in looking at the graph, almost no one, had issues with recurrence early on in the transplant course, up to 1 year, no patients, and then up to 3 years, very little. And then it really takes off late, which makes me wonder a little bit, could some of these be de novo tumors that are driven by HCC coming back and the patients developing recurrent cirrhosis. But then in the case of pathology, they actually do report the path on the patients who recurred, and they were pretty advanced patients who were outside of BCLC criteria in all cases, potentially just very late. And then they broke down patients by Milan criteria and outside of Milan criteria based on their most recent imaging study prior to transplant. And not surprisingly, the survival in patients who were outside of Milan was much worse than the patients who were within Milan criteria. With survival outside of Milan at 10 years being about 52% as opposed to 90% in the patients who were within Milan. It's a small sample size, so it's hard to make too much of the numbers, but I did think it was interesting that even though the rates are so much worse, this is pretty similar to the rates that are reported for the inside Milan patients from older studies. And again, maybe there's some bias because of time and sort of what we've done in the advances that we've seen in HCC therapy.
So do you think that the late, what they call recurrences, where they establish as recurrences and not de novo from recurrent disease?
So they don't say if it's a recurrence or a new one. They just have the pathology from the time of the actual resection. They can tell you that the patients who recurred 6 and 7 had much more advanced tumor than what they thought at the time of transplant.
Nice.
Like some of those patients were recorded as being within Milan or downstage, but they were actually in fact like way outside Milan and had progressed in just that short, time period of a couple of months before transplant.
So, Gusto, what's the quickest practical way to determine molecularly if a tumor is a recurrent?
I think it would be to do copy-number alterations, chromosomal alterations, compare the profiles between primary and true recurrence and the normal are very different.
That's exactly
So the Milan are mostly downstage, right?
Yeah.
Separating out the ones who were downstage to within
Yes.
Milan before transplant.
Because none of the patients enrolled within Milan, because that would contaminate the samples. They're all expanded.
So they
From-
actually
Do include some patients who were downstage to within Milan, but
Yeah, but-
originally they weren't,
Yeah, but the original tumor
was outside, but they're downstage.
yes. Yeah, but it's different to have downstage to Milan that happened without a from. Right?
Yeah.
So this supports downstaging. They have excellent.
And it supports transplanting outside the last. There was 70%.
I mean, these patients are doing really well, 90%.
Well, it's a very extremely highly selected population.
Yeah.
I have to say.
Yeah.
I was in Barcelona when this was.
Oh, really?
It was, 20 patients in 14 years.
In 14 years.
It's kind of a very, very selected.
Barely one patient a year, right? How many do they do transplants there a year?
It was like 80, 90. But the problem is not. 1,000.
That's just 5. So the earliest recurrence was 5 years after, right? For the ones.
Recurrence was 17 months, and then after that it was closer to 3 years, 4 years. Yeah, so there's one recurrence at 17 months. Everything else is out much further.
I thought it was 16 months or after.
Yeah.
Anyway, but is it still feasible that it would be the original tumor?
Oh,
Yeah.
So I remember one patient that was in this protocol and like years after the transplant developed a metastasis, a vertebral metastasis, with a positive biopsy for HCC.
Yeah.
So there's no question that it was a tumor.
Original tumor.
After years, I mean, it was 5 or 6 years.
It's interesting because they're immunosuppressed, so you would think that it would best.
Well, actually, some of the deaths were Hep C recurrent, right?
Yeah.
So those wouldn't happen now.
Right.
Actually, those were the ones that probably happened 14 years ago.
Right.
Actually, so the numbers would actually be better if this was done. This
Yeah.
was done now, because at least half the deaths were from Hep C.
Yeah, for sure. And then this is their composite complications, recipient complications at the top, donor complications at the bottom. None of the patients died perioperatively. In terms of recipient complications, these numbers seem a little high to me. Medical complications in 54%, surgical in 72%. It's a small sample, so very little changes are going to make the percentages look big. And looking at the A2L study from a number of years ago, they do cite complications of like 60% I don't know if anybody else can shed light on sort of what the average complication rate nowadays is. But that seemed a bit high to me. In terms of the donor complication rate, though, it seemed acceptable to me. They reported it at 22%. Again, I thought that sounded high, but it sounds like sort of the appropriate complication rate that's been reported is 31%, so it's still within that range.
Over age is almost like the one from the other study, 33 points.
I know. Apparently we can't do anybody who's over the age of 34 year out one more year.
And even here, I mean,
The GRWR, yeah.
that's also, they have points
Point
in
eight
false.
six.
There's plenty of patients who are small for size.
Right.
Good point. So in conclusion, survival after living donor transplant for patients with extended criteria seems to be comparable to prior reported rates, and in some cases even better than what we've seen previously. I think downstaging to Milan yields superior survival, and certainly the study, as many of us have pointed out already, really supports the role of downstaging. And these patients are doing just as well and sometimes better than what we would expect. And then I already talked about that. So some of the strengths of the study, I thought this was a great study in terms of, its perspective. They had really good follow-up time, and it was well designed. Some limitations, certainly it's a small study, being a pilot study, the samples limited. Feasibility, this is a very carefully selected group of patients. It took them a very long time to recruit. The sample size I did over a 14-year period. So just, how many patients can we really apply this to? Maybe, the one question I have. And then in terms of the recurrence, we've talked a bit about this, but is some of the recurrence confounded in some ways by de novo tumors or maybe mixed in because of the hep C that's occurring and recurrent cirrhosis that presumably nowadays we would be able to treat and not let the patients get to that point. So it may actually be even better than what we see here. Applications, is the risk justifiable to the donor? I think when we're thinking about living donor transplant, this is always the number one question that we have to think about. And looking at the complication rate, it seems lower than what's been previously reported. So from that very basic premises, I think it's acceptable. And then given just a really good outcome, I think it's something that should be considered. And then certainly with the rising incidence of HCC and a high mortality without treatment, especially in light of the changing Milan exception point system, I think this is something that we need to be thinking about because we're able to downstage patients successfully, but how long can we keep them downstage, especially with them having to wait even longer now with all of the tumor exception